Good morning, everyone, and welcome to today's webinar hosted by PYA, Rural Emergency Hospital Program Proposed Rule. PYA is happy to present today's webinar on this important topic. You will have the opportunity to submit questions to today's presenters by typing a message into the questions pane of the control panel. We'll collect these and address them via email after the webinar. And all of our webinars are recorded and released with a copy of the slides after the event. With that, I would like to introduce Martie Ross, Consulting Principal, and Kathy Reep, Consulting Senior Manager at PYA.
Thanks, Trevor. Good morning, everyone. Again, thank you for joining us for today's webinar. The issue of rural hospital closures is not a news story. You see here on your screen probably the latest, most recent report on the subject issued by the Bipartisan Policy Center in May of this year, where they analyzed the financial health of approximately 2,100 rural hospitals. And as you see, they identified most of those about half of the hospitals experienced at least two financial risk factors, where nearly 500 had 3+ financial risk factors, and a group of 178 they identified as truly at high risk of closure given their financial condition. And we've been searching for a solution to maintain access to healthcare in the communities served by these hospitals. But we know the problem. I mean, the issue is one of economics, that for a hospital that has high fixed costs, but a low volume of patients and thus reimbursement from those services, it's just a matter that you can't cover the high fixed costs with the low volume of services. The solution we implemented at the turn of the century was cost-based reimbursement for critical access hospitals, which makes sense in theory, that if you reimburse the hospitals based on their costs, then they should be able to maintain their operations. But remember, cost-based reimbursement is limited to the Medicare share of those costs. And while Medicaid programs in many states also provide cost-based reimbursement, you still have a population of commercially insured and self-pay patients that these hospitals are required to serve, but yet don't receive adequate reimbursement again to cover their fixed costs. So this has been the challenge in rural health, and one solution that in the last 5 to 10 years that has been discussed at length is creating a different type of hospital that does not furnish inpatient services, because that is, in most instances, the driver of the high cost for these hospitals, maintaining those inpatient beds. So could we create a new type of entity to serve these rural communities, to ensure that there's emergency services available, observation services, and certainly transportation to a higher level of care when necessary? And we've seen a number of proposals coming out of MedPAC, out of the National Rural Health Association, several state hospital associations, all promoting legislative fixes. Well, in December of 2020, Congress adopted the Consolidated Appropriations Act of 2021, which you've heard me say many times is the single largest piece of legislation Congress has ever passed. And included in the numerous provisions in the CAA was this new Rural Emergency Hospital Program. CAA was really a true Christmas tree, not just because it was passed in December, but it included so many provisions that because it was a must-pass piece of legislation, lawmakers saw it as an opportunity to include provisions that had sort of languished over the years when they were standalone pieces of legislation. And so that was how we ended up with the REH provisions in the CAA. If you read the provision, which is about 10 pages in the statutory text, you'll see that it is creating a framework for a new type of Medicare reimbursable entity. So a new type of provider to which Medicare will make payments for certain services that entity provides. And that new entity is the Rural Emergency Hospital. And the statute gives us the parameters of how that program is going to operate in terms of what facilities are going to be eligible to convert to REH status, the timing for CMS to stand up this program and begin making payments to REH facilities. That would be January 1st of 2023. The types of services these hospitals will be required and permitted to provide, their conditions of participation in the Medicare program, requirements with regard to quality reporting. In fact, that's the single largest, lengthiest provision in the statutory text. It also outlines the payment provisions and the process for applying to become an REH. All that's in our statutory text. And then it becomes the responsibility of CMS to create the regulations that implement this program going forward. And again, Congress's target was to have this ready to go to begin payments on January 1st of 2023, which I think at this point is a little under 5 months away, believe it or not. So where are we on these implementing regulations? Well, we got really excited the day before the holiday weekend when CMS released a proposed regulation on June 30. This regulation is limited to the REH conditions of participation. So these are the standards that the facility is going to have to meet to maintain its status as an REH and thus receive payments as an REH. Surprise, this proposed regulation also included some changes to the critical access hospital conditions of participation. And as well, Kathy will address those in greater detail, but it was through the review of the COPs for the REHs that CMS identified opportunities to make yet another set of enhancements to the COPs, which is folks that work under the COPs know they seem to be in a state of constant motion. The comments to this rule are due August 29, and you'll notice that that's in bold and underlined, because having spent some quality time with this proposed rule, we think there are numerous opportunities for comment to enhance this regulatory scheme that CMS has created. Remember, our goal here is to create a program for hospitals that are near closure because they are so financially distressed. They are stretched so thin with resources that they need a new payment model to sustain their operations. So this is a question of, and this has been one of the questions as we've talked about these non-inpatient hospitals. Do we view this in the lens of a hospital minus, or do you view it through the lens of an RHC/FQHC plus? And we'll tell you, this regulatory scheme takes this as a hospital a little bit minus. And we need to think about this as, is this a sustainable set of regulations for a hospital when our goal is simply to maintain access in these critical rural communities? I mean, I've been involved in enough rural hospital closures to know that it is a death knell to a community. Not a death knell, that's too strong, but it is certainly an economic punch in the gut. That's probably a better example, when they lose their hospital, because it limits so much economic activity in the community. And so truly, this is lifeblood stuff we're talking about with these rural emergency hospitals.
Marty, before you go to the next slide, I think Marty and I were both in a way disappointed that we did not have the outpatient rule to be able to talk to you about the payment methodology and quality reporting and the like. But the more that I think about it and the requirements under these conditions of participation, I actually think we are better off having you focus today on, can I do this, before we get into the discussion of how do I get paid for it? Because I really think some of these conditions of participation are more like and Marty will go through this, are more like the acute care hospital, large urban setting than they are for a critical access hospital. So when she says acute hospital light, it is not critical access hospital light. And therefore, I think it's something that is very important for you to consider as you develop comments on the proposed rule.
Absolutely. As Kathy referenced, when this proposed rule was published, CMS told us we will talk about the payment methodology, we'll talk about quality reporting, we'll talk about the application process in the ops rule. And we fully anticipated to have an ops rule. In fact, Kathy and I have been a little obsessive compulsive, okay, totally obsessive compulsive, waiting for the publication of the proposed rule. And we were sweating bullets this morning at 8:45, seeing whether it would be released this morning, just in time for this webinar. But as you can see here on the screen, it remains at OMB for final review and clearance. And it is the last of the 2023 proposed rules that is waiting there. In fact, at OMB right now are all of the final rules for the federal fiscal year payment rules. So inpatient, psych, rehab, and hospice, is that all of them, Kathy? Are all there waiting for that level of review. Which one?
Skilled nursing.
Skilled nursing. How can I forget the SNFs? Same on me. And clearly that's going to be relevant here as we get talking on it. So we are certainly planning when the ops rule comes out to provide further webinars on that subject, and then we will, in that context, address what we learn about the payment provisions. And we'll discuss the statutory provisions regarding payment for REHs as part of today's conversation as well, just so you can focus in on all of this. Just to clarify, CMS maintains a separate set of either conditions of participation or conditions of certification for all provider types, with the exception of physician practices. There are not a set of conditions of participation for physician practices, and they vary. They have common themes certainly throughout all of the COPs, but they certainly vary. And when critical access hospitals were created as a provider type, again, back at the turn of the century, they varied significantly from the PPS hospital conditions of participation. Now, over time, a number of the provisions in the PPS hospital COPs have found their way into the critical access hospital COPs. So that would be, most recently, it would be the provisions regarding discharge planning, QAPI, quality assurance and performance improvement, as well as infection control and antibiotic stewardship programs. All of those really have been in the last 5 years brought into the COPs. And as Kathy will talk about here later again, there's one more of these migrations from the PPS COPs into the COPs, and then also into the REH COPs as well. So with all of that, let's start talking about what's in the proposed rule that we have. We begin with, of course, the definition section, and the sole term to be defined is rural emergency hospital, and the proposed regulation mimics closely the language that's in the statutory provisions. It is an entity that cannot provide inpatient services, of course, with the exception that if they operate a distinct part unit that is licensed as a SNF, a skilled nursing facility, that can be provided post-acute services on an inpatient basis. What the entity must, go ahead, Kathy.
Question right there. They address providing services as a SNF, but a critical access hospital could have a SNF, it could have rehab, it could have psych as inpatient.
Right, and as these proposed regulations stand, again, based on the statutory provision, there is this allowance to have a distinct part unit licensed as a SNF. Now that's
SNF
not
only.
that, right?
SNF only.
SNF only.
But not rehab. So a patient would not be able to come back to their community for rehab in a distinct part.
If they require that level of care, right?
Okay, thank you.
Yeah, but I think right there we've given away part of the story, and this will be more relevant as we talk about the payment provisions. But no longer can you have cost-based reimbursement for swing beds. That if you opt into the REH program, you give up your swing bed reimbursement, and instead you have to turn that operation into a skilled nursing facility. And again, you're going to have to meet the skilled nursing facility COPs, which are more demanding than typically has applied to swing beds. and you will be under the payment methodology for skilled nursing facilities. What a REH has to provide, it is required to provide emergency department services and observation care. Those are the core services to be delivered through an REH. It may also then, that facility may also opt to provide, quote, other outpatient medical and health services as specified by the Secretary. And as part of the COPS, we dig in deeper into the requirement for those other outpatient services. Just as critical access hospitals are limited in how long they can keep a patient as an inpatient, REHs are limited in the length of time that a patient can remain at the facility. That on average, the annual per patient length of stay cannot exceed 24 hours. Now, as part of its development of these regulations, CMS solicited comment, it was a request for information across a series of questions to stakeholders. That was part of the 2022 proposed ops rule. And CMS received numerous responses to that RFI. Several of those folks that provided those responses noted that one of the experiences through COVID has been this, oftentimes hospitals end up holding these patients longer because the PPS hospital to which the patient needs to be transferred doesn't have a bed. And so what had been a 3-day stay becomes a 6 or an 8-day stay waiting for a bed to open at the PPS hospital. Now, for purposes of the public health emergency, there were leniency given to permit those costs to keep those patients longer, but it certainly appreciates that if you're going to be dependent for any patient that requires inpatient services, you're going to have to transfer that patient in as REH, that there are going to be circumstances that are not at the level of a public health emergency, but would prevent a transfer within that period of time. CMS's response to those comments is, well, we don't think it's going to happen that often, and we really don't think there's a risk that they would exceed their annual provision. Here's a great opportunity for a comment. Yes, the statute requires a 24-hour limit, but it defers to CMS on how that 24 hours is calculated. So CMS could adopt a regulation, we believe at least, that would exclude certain encounters, patient encounters that were longer observation stays that were necessitated by the lack of an available bed at an inpatient facility. So rather than say, well, we don't think it's going to happen, it seems to make sense to us that you would provide on what it can likely become, and could become, based on our experience, a pretty common experience for these REH hospitals. Next up, we'll talk about the eligibility provisions. And again, this is going to mirror the language from the statute. So if you are a facility that, as of the date of passage of the CAA, December 27th of 2020, you have to be a critical access hospital or a PPS hospital with 50 or fewer beds in a rural area. You see here on the screen the two ways the regulations define in a rural area for purposes of the regulation. Now, when the CAA was passed, many of us were, one thing we noted about the statutory provision was that it didn't provide an option for communities that had already lost their hospital because it required it to be in operation at the time. But now that we've had kind of a 2-year break between the passage of the legislation and where we are today, we know there's a possibility of other hospitals closing before the REH regulations are stood up. So does the regulations now create an option to convert to an REH facility to become an REH facility for a facility that was operational as of the passage date, but is not at the time that the regulations actually become effective? So that's a question we'd like to see CMS answer in its final regulations as well. The other requirement for eligibility is that this facility has to be located in a state that provides for the licensure of rural emergency hospitals. And it in fact must have accomplished such licensure or approval by the appropriate state agency. So as it stands today, according to the Office of Rural Health Policy, the only state that has created such a statutory scheme is my home state of Kansas. I've cited there the statutory provision that creates the REH licensure rules. So your state can refer to the same if you intend to run a piece of legislation for purposes of creating an REH licensure provision. This is due to the fact that state licensure provisions typically call for inpatient beds and inpatient coverage. And thus, we have to have a way to make sure that the state is satisfied with the services provided by this entity in advance of Medicare then determining it is appropriate to enroll that entity for purposes of Medicare reimbursement.
And that becomes an issue that I think hospitals and hospital associations need to be looking at right now, because if you could be up and operational as an REH in January of 2023, many states will not have session again until the spring of 2023. If it becomes this question of getting this on your legislative agenda at a state level, right, to make that change.
Exactly. Or it's a matter of getting the regulatory agency, the State Department of Health, that currently regulates hospitals, to interpret those regulations in such a way that would permit REH licensure. I think that's the other route you could go. I think most folks are going to create greater comfort from having statutory provision in place, but there is that other route that one could pursue. So let's get to the meat and potatoes, which are the proposed conditions of participation. You see the full set here on your screen. We're not going to go through all of them. I simply want to highlight some key provisions that I think are open for, that Kathy and I believe are open for comment. The ones we do not comment on generally track the existing critical access hospital COP. And so given that most facilities that are going to, that would be likely to convert or cause today, they would already be in compliance with those particular conditions of participation. Now that raises an interesting question. How many hospitals do we think are in line to convert to REH status? So HRSA funded a study done by the North Carolina Rural Health Research and Policy Analysis Center. And they determined that they're based on their criteria that they applied. And their criteria was 3 years of negative total margin, an average daily census between acute and swing bed of less than 3, and net patient revenue of less than 20 million. So they said, what hospitals meet those 3 criteria? They identified 68 hospitals at the time that analysis was performed. And CMS then uses that number 68 to do its analysis on the cost of implementation. So it's not hard and fast. There are certainly other hospitals that may elect to pursue this. Some of those 68 hospitals may elect not to pursue this for some reason. But that's sort of the number we've been working with in terms of conversion. So let's start with emergency services, certainly because that's the core operating, it's in the name, right? Rural Emergency Hospital. The Consolidated Appropriation Act required that CMS create conditions of participation that hold REHs to the same standard as critical access hospitals with regard to emergency services. So as you look at the proposed rule, you will see the REH COP tracking very closely the COP for emergency services, and specifically these 5 requirements: 24-hour availability of services, rules with regard to equipment, supplies, and medication necessary for life-saving interventions, the availability of blood and bread products, personnel staffing in the facility, and then the coordination of emergency response system. Let's drill down in particular on the requirements with regard to personnel. So we know the COPs require that either a physician or a non-physician practitioner be on call and immediately available by radio or telephone contact, and also be available on site within 30 minutes. There's an exception for the 30-minute rule if the facility is located in a frontier area or a designated remote location. And they have formally determined that they cannot comply with a 30-minute rule. So this is the whole process that a COG goes through to opt for 60 minutes as opposed to the 30-minute requirement. And we know as CMS is applied, this COP on site means physical presence. Again, exception made through the pandemic to allow this to be a telehealth supported presence for purposes of meeting this condition of participation. There are also provisions within the COP and thus now the REH COP that an RN can satisfy this personnel requirement on a temporary basis if the CA has gone through the process of demonstrating a temporary shortage of personnel that necessitates the use of an RN for such coverage purposes. So where it stands today is if you want to change the rules for a rural emergency hospital, you're going to have to accomplish that by changing the critical access hospital COP. So if you want to comment on this provision and say we need to address the availability of rural services differently, i.e. using telehealth to meet this requirement post-pandemic, you need to going to propose that as an amendment to the COP because the statute requires that the REH COP mirror the COP. It says very clearly in the statute, it references the particular regulatory provision and then it says as subsequently amended. So it's not freezing in time the personnel requirement for REHs. It's affording the agency the discretion to amend the COP for cause, which then would change it for REHs. So there is a vehicle
not
here.
Propose anything related to that for the cause in this round?
They did not, no. Despite, again, the critical access hospital community saying this has worked great through COVID. We've had much quicker, it's been better. We're getting access much more quickly. We are able to communicate via telehealth effectively. Please give us a reason why we still require physical presence. When you've got qualified nursing staff present in the facility, that certainly can facilitate the examination and treatment. And again, these are our hospitals that are on the edge. And part of the reason they're on the edge is because of their lack of physicians and non-physician practitioners in their communities that are available to take this effectively what could be 24/7 call requirements if this stands going forward.
But if you are a CA not considering becoming an REH, you need to comment on this rule saying they need to make this modification for the CA COPs. Encourage them to get it done.
Exactly. And certainly citing your experience through the pandemic, if you have used telehealth coverage for purposes of meeting your personnel requirements. So let's talk EMTALA. The Consolidated Appropriation Act, also in addition to creating this new provision in the Social Security Act for REHs, also goes in and amends the EMTALA statute. And it includes in the definition of hospital for purposes of EMTALA, rural emergency hospitals. So the REHs have been swept in under EMTALA. CMS, however, has not proposed any changes in this rule to the EMTALA implementing regulations, nor Appendix V of the State Operations Manual, which gets into the, as you know, the nitty-gritty of EMTALA compliance. So as it stands today, even if this rule were to be finalized, the EMTALA regulation still defines hospital only to include critical access hospital. It does not make now reference to an REH as part of the definition of hospital, and CMS has not addressed that. So again, for the sake of clarity, I think a reasonable comment would be, please address the EMTALA requirements for these hospitals. The only reference, and thank goodness for the seek and find function on PDF, the only reference to EMTALA in the proposed rule is what you see here on the screen. And I apologize for the typo because it should say one commenter recommended that EMTALA waivers be provided to RHCs to divert, not divert, patients from other hospitals that require a higher level of care. This has always been the issue with EMTALA is the patients coming to your facility, you want to say, don't come. We know based on what you're telling us that you need a higher level of care. And EMTALA has always come into the discussion there as to providing stabilizing treatment. And this, as commenters raise this, is like we should be able to, as we develop our continuum of care as an REH, we need to be able to tell patients in these circumstances, it is best for you to proceed immediately to a higher level of care. And CMS's response to this comment was simply, the statute says they're subject to EMTALA, and so we can't waive EMTALA. But again, CMS has the authority to write the EMTALA regulations, which we all know go beyond the statutory language, and certainly could provide of how an REH's obligations under EMTALA apply. So again, we think this is another area ripe for comment to the agency. There you go, a little more detail on some of these provisions. Again, for the most part, we tracked the critical access hospital costs, but sometimes we haven't. So what you have on your screen here is print way too small to read. I appreciate that. What is in red is the condition of participation for PPS hospitals concerning radiologic services. What you have in green is the critical access hospital condition of participation for radiologic services. So which one, Kathy, do you think CMS chose for REHs?
Red.
Red. So if you look at the REH proposed rule, the language for this COP tracks the acute PPS hospital. Their reasoning for electing to do so is that, well, the state operations manual goes into greater detail for the critical access hospital. So in effect, it's fine to use the PPS provision. But as you see, that if you go into the SOM, it is not at the level of detail that the acute hospital requirements are. And thus, this is one area, certainly if you're only operating as an emergency department and providing observation services, that there is an opportunity to simplify, not require a cost. If we have a critical access hospital that's looking to convert to REH status, they're actually going to have to do work to enhance their policies and procedures with regard to radiology. Again, another opportunity for comment to the agency. Pharmaceutical services, what you have in red is what applies to PPS hospitals. What you have in green is the rule applicable to critical access hospitals. Spoiler alert, I'm not even going to ask you this time, Kathy. They opted for the PPS hospital CAW for inclusion in the REH. And again, this is certainly an instance where the PPS hospital requirements are more particular and onerous than what a CAW operates under. And think here, you're gonna have a much more limited range of pharmaceutical requirements if you're only operating an emergency hospital. So again, opportunity to right size the requirements to an REH. Next up are the rules regarding additional outpatient services. Remember, you've got to do ER, you've got to do observation, but if you want to do more, if you want to maintain other outpatient services that your critical access hospital or your rural PPS hospital has had, you're going to have to identify those in your application per the requirements of the Consolidated Appropriations Act and explain how you're going to use those services. And again, in the CAA, Congress deferred to CMS to say what are the conditions under which you'll approve other services being provided by an REH. And the answer is in this proposed COP. They say that you are permitted to provide items and services that are typically primary care based services. And that's going to include entry point services such as radiology, laboratory, outpatient rehab, surgery, maternal health, and behavioral health services. What's missing from that list? Therapy. And that's a concern for many rural hospitals. It is your provision of respiratory therapy, physical therapy, occupational therapy to your community that is critically important. And hopefully this is a not limited to instance, but again, opportunity for comment. You then have, below that text, 6 requirements that a REH must satisfy with regard to each additional outpatient service it provides. So it has to provide that service based on nationally recognized standards. It has to have a system for referral to a higher level of care as appropriate. It has to create an effective communication system between the REH and the patient and their family to ensure that the REH is responsive to their needs and preferences. I know I've got a little attitude in my voice because there's no comparable condition of participation for hospitals or critical access hospitals today. So if we're going to offer an outpatient service, we have to create a new communication system specific to that particular service. I don't like cops when they don't tell me what to do. And here, this seems more aspirational than directional, which I think always create mischief. At least I've always seen mischief in survey circumstances when you have these types of provisions included in COPS. They are also required to have established relationships with hospitals that have resources or the capacity to deliver higher levels of care beyond the scope of an REH. So if you're going to have X service, you're going to have a relationship with a PPS hospital to which you can make referrals, continuum of care type notions. You have to have the appropriate professional and non-professional staff necessary to deliver that services. And then if you have selected surgical services or procedures that require the administration of anesthesia, there are additional specific requirements that are included in this COP. This one I think needs attention, specifically that provision about, I understand you certainly want to right size the service to meet the patient's needs in your communities. And if that is appropriate, there has to be a more concrete way of accomplishing that than creating some communication system. I don't like opportunities for mischief. And this particular provision under close scrutiny, I want you to think about how this would look in the future in a survey for you as you work on preparing comments here. Next up is quality assurance and performance improvement, QAPI. So the CAUs have been dealing with QAPI. They've been required to comply with QAPI since 2021. And it is still a matter in its infancy. And the entire rulemaking process as that requirement became applicable to COPS was really, became applicable to CAUs, I'm confusing my acronyms, was really actually a great experience in that it was a high level of commentary by stakeholders. CMS was responsive in terms of how it tailored the COP to meet CAUs requirements. And specifically, I've cited here the provision in the COP regarding governance and leadership's engagement in the QAPI process. When it was proposed, when this provision was proposed by CMS, it included the language in red. So very prescriptive provisions with regard to the role of governance and leadership in the QAPI program. What you see in italics at the bottom of that box is the language from the final rule that approved the new COP for QAPI for cause. Say that 3 times fast. But you'll see there that they said this was unnecessary. We understand that these facilities need to right size their programs to the scope of services that they provide. We're going to withdraw this additional language, and we want them really to have the flexibility to create the best program that operates most efficiently within the restrained resources they have. Apparently, the lesson learned in publishing that rule in 2019 did not stick, because what you see then in the proposed rule for REHs is a standard regarding executive responsibilities. And you see here, rather than mirroring the somewhat flexible language that appears in the final version of the COP, you instead have, again, an enumeration of specific requirements, boxes to be checked by that that entity with executive responsibility for the program. This is an opportunity. Again, I sound like a broken record, but here we need to go in and comment, because an REH, again, it's intended to be smaller. It's supposed to be a contraction of services so you can operate financially, and yet we're piling on here with additional requirements. Now, you may not view these as onerous on first glance, but you are still addressing additional processes. And given that the typical critical access hospital administrator has an entire hat store of roles that they wear, to add these responsibilities with regard to QAPI, which aren't even in the COPs now because they were taken out, certainly complicates that process of conversion. Next up, the provision regarding agreements. In the statute, again, back to the CAA, Congress required that an REH have an agreement with at least one level 1 or level 2 trauma center regarding the referral or transfer of patients requiring emergency care beyond the REH's capability. Now, the staffer that wrote this in the legislation probably would benefit from looking at a map of where level 1 and level 2 trauma centers are located. Here in the state of Kansas, I believe we have 2 level 1s and 3 level 2s, I think. If you're in Western Kansas, you are hundreds of miles from the closest level 1 or level 2. And in most instances, that is not the facility to which you would be transferring a patient. You would be transferring them to the closer level 3 PPS. But despite this being pointed out to CMS, they said that's fine. You can have additional agreements with other hospitals, but you have to meet this statutory requirement of having an agreement with a level 1 or level 2. You could have, but in the regulations, there are no standards with regard to any of these agreements. So yes, you have to have an agreement, but we have no specifications with regard to what are the receiving hospitals' obligations to take your patients. EMTALA may be sufficient for that purpose, but certainly you want to look at your experience in transferring patients to hospitals, especially with the COVID experience, and what would you want these agreements to look like? Another topic related is a comparison between the COPS and the REH COPS. A CA is required to be part of a rural health network, and there is a COP that details what a rural health network has to look like and what it has to do. And it certainly was an attempt to create, again, this rural continuum of care. How do we move patients in rural communities seamlessly to higher levels of care and back home again? And that was the purpose, if not necessarily what was achieved, with the inclusion of these rural hospital network provisions in the CA rules. No such provisions in the REH rules. You are an island with one thin thread back to your level 1 or level 2 trauma center, at least as the regulations read. Certainly as you move forward, you would have broader relationship, but you will not have any of the authority under the regulations as you pursue those relationships. So again, another opportunity, this time asking CMS to do more, to provide more direction, both to help the REH as they work for these relationships. Finally, just a few other record. Well, come on. Oh, I think it went to sleep on me. Just a second. There we go. Just let's wrap up a few others. There's a provision regarding the infection prevention and control and antibiotic stewardship programs, those new COPS that went into effect, I think, in 2020 for critical access hospitals. The provision of the REH tracks the COPS with the 2023 proposed changes. Kathy will tell you all about that. There is a discharge planning COP that tracks the provision that applies to COPS that was amended in December of was effective in December of 2019. It's identical language, but don't you think discharge planning is going to look different if you don't have any admissions? Should we be, the language is broad enough, is one wonders for which patients do we have an obligation to do discharge planning versus discharge instructions. And remember, the regulations make a clear distinction that discharge planning is more than just instructions. And then there's also the provision on patient rights. Again, that's the last of the migrators from the hospital COPS into the CA COPS to have those additional patient right responsibilities. We're going to take them right over to the REHs as well. Again, that's Kathy's job here in a few minutes. Briefly, let's talk about the REH statutory provisions regarding payment. And again, this is the preview of what you'll hopefully see in the OPS when, hopefully not if, it's published. An REH no longer receives cost-based reimbursement. Instead, it is paid for its services at 105% of the applicable outpatient rate. Of course, that's subject to sequestration. So don't forget, that would be it. There's a good comment. Dear CMS, can we accept REH payments from sequestration going forward? SNFs are going to be paid at the SNF PPS rate, so you will lose your swing bed cost-based reimbursement. Despite the fact you operate those swing beds more efficiently and get patients have much lower lengths of stay in swing beds, you're now going to be under the SNF rules. The ambulance fee schedule is going to apply for REH furnished services. So if you are a REH that, a CA, excuse me, that operates its ambulance and you're not within 35 miles of another facility, you're going to lose that bonus reimbursement that you receive. You will be a telehealth originating site, but no provision to be a distant site, i.e. no billing for telehealth by a REH, the delivery of telehealth services versus the originating site fee. You'll be able to maintain your provider-based rural health clinic status, but the language is vague in the statute because it's not clear whether you'll maintain your cost-based reimbursement for your RHC, excuse me. As you recall, the CAA, another thing it did was eliminate future cost-based reimbursement for rural health clinics. For those provider-based rural health clinics that have cost-based reimbursement historically, they can maintain it. The question here, if you convert from CA to REH, do you lose that grandfathering protection? We certainly hope not. That'll be important. We'll want to see commentary. And then the thing that sort of makes me pull my hair out is there are certain services that aren't reimbursed on OPS. Physical therapy, occupational therapy, speech language pathology services, those are reimbursed on the Medicare physician fee schedule, not the OPS.
And mammography.
Mammography, thank you, Kathy, I forgot one. But there's no provision for a 5% bump in the statute. Certainly CMS has the authority to make that provision, I believe, when it writes the regulations, and we want to encourage them to do that as well. The other part of the payment for an REH is the additional facility payments, which all REHs are going to get the same amount. This doesn't vary by size or location or anything else. This is just a formula, a calculation that CMS makes, and it is what it is, and there's no judicial review. And it is based on, ready, follow carefully, the difference between what critical access hospitals were paid in 2019 under cost-based reimbursement versus what they would have received if they had been reimbursed at the PPS rate. Take that number and divide it by the number of CAUs in 2019, which is around 1,300, although there were closures in 2019. So do we use the number before the beginning of the year or at the end of the year? We'll just have to see what CMS does when they publish this number. I have not seen any close to even reliable or anyone willing to make an educated guess on what this number is going to look like. Certainly it's going to be the make or break, because this is going to be that amount that hospitals will rely on to cover that difference between their higher fixed costs and what they receive in reimbursement. You are also going to be required to report on how you use this additional payment on a going forward basis. I'm going to skip this since we're a little short on time. But the other concern we have is what's going to happen with other payers. With regard to Medicaid, there's no provision in the CAA that addresses Medicaid payment to CAUs, to, well, what I'm supposed to be saying is REHs. Even I lose track of my acronyms sometimes, I apologize. There's no Medicaid reimbursement addressed for REHs in the CAA. That's what she meant to say. There's no CMS guidance on this as well. There's the open question of eligibility for DISH payments as these hospitals go forward. What are going to be the state plan amendments we're looking at? What's going to happen with MCO contracts in terms of how they've paid CAUs previously? Will they apply that same formula to pay REHs? This is all to be determined and really no direction. For Medicare Advantage plans and commercial payers, it's probably back to the drawing board in terms of what your contract negotiations are going to look like with these entities. There are many analyses that show a contributing factor, a significant contributing factor to many of these hospitals' financial challenges are their low payment rates from Medicare Advantage and commercial payers. And are we simply going to dig the hole deeper as we move to REH status? Finally, statutory provisions on the application process as we look forward. You are going to have to provide a transition plan. So, and again, we'll see the detail of this hopefully in OPS as to what this application process is going to look like, because it is an application and a certification process through CMS. But you're going to have to talk about the services you're going to modify, those that you're going to retain, when you're going to discontinue, and what you're going to add. You're going to have to describe how you're going to deliver observation and emergency care services. You're going to have to then talk about how you're going to spend the facility payment, which I think you say covering our operating costs would be a good answer, and any other information that CMS chooses to include in the application itself. So with that, I'm going to turn this over for our last 10 minutes with Kathy to discuss those mirrored changes to the COPS.
Thanks, Marty. And I'm going to go through this very quickly, but I guess I'm going to start right now and emphasize the same thing that Marty has done. You've got to take a look at this rule. You've got to comment on this rule, whether you are a CA, staying a CA, or whether you are a provider who is considering becoming a rural emergency hospital. You have to comment. And of course, now, yard work. Okay, so in terms of the proposed changes related to the CA conditions of participation, When I hear the word COP, I just want you to know, Marty, I kind of panic. But we will talk about the revisions that are proposed. I think that you are aware of the fact that unless you are considered a necessary provider, a critical access hospital has to be located no more than a 35-mile drive on primary roads from another hospital, from a hospital or CA. There is the exception for that if there's an issue of mountainous terrain or if there's only secondary roads available. So CMS, in this proposed revision to the particular location provision, they are proposing to define primary roads. Remember, we've got primary roads 35 miles, secondary roads 15 miles. So they are saying that a primary road would be a numbered federal highway or an interstate, etc., or a state highway with 2 or more lanes each way. So this is actually giving some clarification as to what is considered a primary road in terms of the determination of whether or not a facility would qualify as a critical access hospital. Gut feel, I don't think I was going to say, I don't think anyone's going to have a problem with this provision, but yes, Marty.
Except in the state of Missouri, highways are not numbered, they are lettered.
But is it a federal?
Oh. It's a state highway. It's lettered instead of numbered. Just for what it's worth. Okay, sorry.
Okay, thanks. Geesh, what next? Okay. In the issue of the status and location, and particularly if you are in a state that does not have certificate of need, this becomes a major provision because every 3 years there is that review of distance and location for critical access hospitals. If there are no new hospitals within 50 miles of the CA, existing CA, then you would be immediately recertified. However, if a new hospital has sprung up within 50 miles, prior to recertification, there's going to be a review based upon distance and the definitions of primary roads or mountainous terrain. If you fail this review, then you would be considered non-compliant and there could be enforcement actions. If you are in that state without CON laws, a new hospital, a new facility could pop up fairly quickly, particularly in light of some of the, in light of some of the hospital-based freestanding emergency departments that are springing up, being built large enough to immediately add beds. Beds are being added because there is no CON, and they are suddenly within your community. So I think this does begin to jeopardize some of the critical access hospitals that are out there today in terms of another facility appearing within your market. Under the patient's rights, Marty talked a little bit about the provisions related to patient's rights and the requirement that this would, the revised COPs for critical access hospitals would be applied to the REHs. But some of the things that they are looking at, and these pretty much parallels the requirements of a PPS hospital, but that you would be required to notify patients of their rights, provide them immediate information related to how to file a grievance and resolve any grievances to the best of your ability immediately. Also including information for the patients if they want to have a dialogue with a quality improvement organization related quality of care concerns or premature discharge. You have to make that information available to that individual. The patient has the right to participate in the development of their plan of care, and that includes compliance with advanced directives. If the patient does not want any resuscitative measures taken, you must comply with the patient requirements, and you must work with them from an advanced directive perspective. involving the patients in their plan of care or their family is vital under this new rule. They are also looking at expanded provisions under patients' rights. Again, something that exists for the PPS hospitals now, but this relates to the use of restraint and seclusion. It doesn't say that you can't use restraint and seclusion, but it really looks at when it's used and what you're required to do. You can only use restraints and seclusion to ensure the immediate physical safety of the patient, a staff member, or others. It must be discontinued as soon as possible. You're going to have to do staff training on restraints and seclusion, and report deaths that are associated with restraints and seclusions, not just those patients who expire while in the restraints, but those who have been removed from restraints and expire within 24 hours, but it is reasonable to assume that the restraints or seclusion attributed to the death of the patient. Those are going to have to be reported, and they have to be reported no later than the close of the next business day following knowledge of the patient's death. So again, this is increases the administrative burden on facilities. This would go over as well to the REH because they are adopting the revised COPs for critical access hospitals. In terms of staffing and staff responsibilities, I think I would say the next couple of provisions really get into for those who are participating through a multi-facility system, multiple CAUs, multiple PPS hospitals, you are going to be able to operate in a more unified and integrated manner. First, as far as staffing and staff responsibilities, if your medical staff across the various facilities agrees, then you can have unified medical staff bylaws that explain credentialing, privileging, etc., peer review policies. You can create a single document or a policy across the facilities as opposed to per facility. They are also proposing, go back, okay, as it relates to infection prevention and control and the antibiotic stewardship program. Again, it would allow the governing body of the CAU, if it is a part of a system that has a single governing body, then that the governing body can elect to have an integrated infection control and antibiotic stewardship program. However, you've got to make sure that if you do this, that each facility within the program has qualified individuals with expertise in infection and prevention and control, and that each facility maintains policies and procedures, provides staff education and training, but you can have a single program across the multiple facilities.
Hey,
Marty,
Kathy, you talked about a great comment. A great comment there is, instead of saying single governing body, why don't we use the rural health networks? I mean, the CAUs have these networks, and granted, it's not shared governance, but they have contractual relationships among the CAUs. And this is the perfect. Most CAUs are independent still these days. I mean, they're governmental hospitals, they're sole community hospitals and the like, and they're not part of systems. And this is our intention here, to drive them towards systems, or is our intention to allow for coordination and collaboration among facilities? And in this instance, I don't know if single governing body is the critical test, instead of part of a network has an agreement to share resources with other hospitals. So it's at least contractually enforceable, if not necessarily through the governance process. So I think this is
and maybe comment that should be an option, single governing body or. I think that is an excellent comment, and something I think would be very good for the cause to consider.
And QAPI is in the same boat as infection prevention and control, I think. So just absolutely. More opportunities to build those rural health networks in these communities. Okay, what's coming?
Well, there is so much coming. It's really kind of scary. First of all, we're going to get off of our usual Wednesdays And actually, not only are we getting off of our usual Wednesdays, but we're getting off of our every other week, because you're going to be hearing from us next Thursday on the physician fee schedule proposed rule part 1, where we were going to talk about the conversion factor, appropriate use criteria, care management, telehealth. That will be phase 1. Then we're going to have, I think this will be Valerie Rock, who is going to do on August 3rd, more getting into evaluation and management, some of the split shared visits provisions, et cetera, under the physician rule. And finally, there will be on August 10th, notice we have just kind of moved out of this every other week. Lori Foley is going to address some of the quality payment programs under the physician fee schedule. When we have an outpatient rule and we're wondering where it is and why it hasn't dropped, then you're going to hear from Marty and I on the outpatient rule, and who knows, it might wind up being later in August, or it could be earlier in August if we suddenly just say, we've got to get this out, there's too much information. And depending upon what that rule says, it will be a question as to whether or not we do it once related to REHs, and then the other outpatient provisions, or how we actually divide that one up. And then last but not least, from Marty and I, we've got all the final rules that are coming out, and they should start being released in August. So you're going to hear from us on inpatient, rehab, psych, and skilled nursing. And some way or other, we're going to sneak hospice in there as well. Right?
Oops, yeah, I know, my bad.
That's okay.
I forgot him.
And in case you haven't gotten tired of us, next week, no, in 2 weeks, we're offering our 2022 Summer CPE Symposium, What's Hot in Healthcare, and recognize that this is the first of a first annual event. I do believe it will be annual. This will be run over 2 days. There will be CPE available. And we've got a lot of different topics. And I will say that I'm talking about pricing transparency using the data along with Jason Harden. And Marty, your topic is?
I got a pass on this one, Kathy.
Did you? Okay, that is not fair. That is really not fair. So you'll be hearing a lot from us. We urge you to provide in any questions in the evaluation that you're going to get, and as well as any additional topics that you want us to cover. Not that we haven't booked you for the next month or two, but provide us any additional topics you would like us to cover.
And as always, as Trevor told you at the beginning, if you have specific questions, throw them in the chat. We actually do respond. Believe it or not, Kathy is diligent every other Thursday morning, though it seems more frequently. We go through them and send responses, so don't hesitate. Thanks again for joining us, and have a great day.
Take care.
Thanks
Trevor?
to our presenters, Marty Ross and Kathy Reep. If you have any questions, their presentation and contact information will be emailed to you, along with a recording of today's webinar. Also, if PYA can provide assistance with audit, tax, compliance, valuation, or physician services, call or email us. You may also visit our website at pyapc.com for more details about our specific areas of expertise, or to subscribe to receive PYA insights. Please remember to stay on the line once the webinar disconnects to complete a short survey. On behalf of PYA, thank you for joining us and have a great rest of your day.